The following program is sponsored by Community Psychiatric Centers and is produced for educational purposes only. It is not intended as a substitute for medical or psychological advice, diagnosis, or treatment. The content should not be used for self-diagnosis or treatment of any health-related condition. As always, seek the advice of your healthcare provider with any questions regarding a medical or mental health condition.
Welcome to Community Psychiatric Centers Presents. Tonight, children and sleep problems. Anyone who's ever had a child or babysat one knows what a challenge it can be when a child has trouble getting to sleep or staying asleep. So what can be done to help both parent and child conquer the bedtime blues? To wake us up to all the possibilities, let's meet our experts. Dr. John Carasso is Clinical Director of Community Psychiatric Centers. He's a clinical licensed child psychologist and a certified school psychologist. And Dr. Robert Lowenstein is Medical Director of Community Psychiatric Centers. He's a board-certified child, adolescent, and adult psychiatrist and a fellow of the American Academy of Child and Adolescent Psychiatry. Good evening, gentlemen.
Good evening.
Dr. Lowenstein, how common are sleep problems for children, and what are some of the typical ones that kids face?
Sure. Sleep problems are actually pretty common in children. There are statistics that came out that show that up to 37% of school-age children have significant sleep problems at one time or another in their life. There are other statistics that show that 33% of children up to the age of 4 have difficulties in a child's ability to sleep throughout the night. So it's a very common problem. Now, the kind of sleep problems that children can face can include trouble falling asleep, trouble staying asleep, early morning awakening, night terrors, nightmares, bedwetting. All of these things interfere with sleep or are symptoms of a sleep disorder.
Dr. Carasso, when children don't get enough sleep, what kinds of problems can that cause?
Well, it's miserable for everybody. It's miserable for the child, for the parents. It's a very difficult time. Research has shown that there's what's referred to as a negative correlation between sleep and behavior problems as well. For example, the less sleep that a child's getting, the more behavior problems that are demonstrated the following day, which I suppose would make sense. But more alarming is that recent research found that that preschoolers who were getting less sleep had almost a 25% greater chance of developing a psychiatric diagnosis down the line, which is really quite alarming. So it's something to be taken seriously. The child's not getting enough sleep, it impacts all aspects of functioning, as well as the family's functioning. Siblings as well end up getting their sleep disturbed, and so it's something that can be treated, but needs to be taken seriously.
Dr. Lowenstein, how much sleep do children actually need? Is there some type of way of knowing?
Yeah, there are some guidelines that we follow in terms of what young children need in terms of sleep. The statistics are that basically young infants usually need at least 16 hours of sleep a day. Sometimes they sleep a good part of the day away. These are young infants. Babies from 6 months to 3 years of age or toddlers really need anywhere from 10 to 14 hours a day of sleep. Children aged 3 to 12 may need anywhere from 9 to 12 hours of sleep, and teens tend to sleep around 9 hours a night, which is about average. As we get older in life, we tend to need less sleep, so that adults and older adults tend to need less and less sleep, going down to maybe 7 or 8 hours a night as being sufficient.
Dr. Carasso, what would you say are the most common sleep problems you see in your practice?
What we tend to see most is children having difficulty going down for the night, staying down and not being up all night, and bedwetting is a very common one as well. It's tough making that transition from being up with the family and going to bed. There's separation anxiety issues, missing out on what's going on in the family, and that can be tough. Sometimes children struggle with any number of issues that keep them up throughout the night, and of course bedwetting is something that a number of treatment measures for that as well. But again, that can be a difficult problem for kids.
All right, we're going to take a short break. When we come back, we'll take a look at ways to help your child get to sleep and stay asleep. Stay with us. You're watching Community Psychiatric Centers Presents on PCNC. Welcome back to Community Psychiatric Centers Presents. We're talking with Dr. Robert Lowenstein and Dr. John Carasso about sleep problems you might be having with your child. And Dr. Lowenstein, what are some of the common treatments to promote a child going down and staying down?
Right. The professional consensus is that before we give any medications to children to help them go to sleep, we have to introduce some behavioral interventions or a routine, which is called a good sleep hygiene, that we implement in the home to help the child go to sleep routinely. The kind of things that help are, for example, I help the child to prepare to go to sleep in a routine fashion. Put them to bed, maybe tell them a story, maybe sing to them, soothe them, take a bath before they go to bed. Importantly, don't help stimulate them before they go to bed, such as exercise or roughhousing or permitting them to watch TV late into the night or play games. Routine is very important. The second is to try to set a consistent schedule. A child should know when bedtime is, and it should be pretty much the same every night. Not, you're allowed to stay up till 12 o'clock one night and the following night you have to go to bed at 8. It doesn't work. It has to be fairly routine. For young children, it's important and can be helpful to let the child take a teddy bear to bed for them, or a blanket which soothes them, or some special toy. It helps to give them a sense of comfort and security. If they like a night light to stay on, or they want the door open, that also can be helpful. Important not to introduce anything that helps jar them or make them stimulated. Make sure your child is comfortable. The room can't be too hot or too cold. It can't have too much light, and it can't have too much noise. So you try to really make it fairly comfortable for them to be able to sleep. Important to make the child sleep in their own bed. Don't let them crawl into your bed at night. Don't make it easy for them to call for you in the middle of the night so you'll come to them at a moment's notice. Give them some time before you rush in to try to soothe them, and give them some peace and some space.
Dr. Carasso, what about some other strategies that you would recommend to parents?
Sure. The behavioral strategies that Dr. Lowenstein mentioned begin with data collection, information. We need information. And so we'll have parents at times do what's called a sleep diary, which helps to gather information about what goes on before bedtime, during the bedtime event, and then throughout the night, sometimes even the next morning. And that information is very helpful. There's lots of other things as well, though. We want kids outside during the day in the sunlight, playing, being active. Sunlight's very important for melatonin levels. But then as the evening approaches, we want things calming down. We want lights dimmed. We want things to be quiet. That helps to get melatonin levels back up again. To have them drop. And then as well as we want to avoid stimulation, as Dr. Lowenstein mentioned. We're looking for, if children need parents to be with them to help them soothe, to get into bed and stay in bed, we want them to sit with the child, not lie down with them, and try to get out as soon as possible. Sometimes we'll use what's referred to as the 3-pass strategy, where the child may be provided 3 passes that they can use to get a drink of water, to get a hug, to get whatever they need. But once those 3 passes are used, then that's it, they're staying in their bed. Research has found that the majority of times children won't even use the 3 passes. Just knowing they have them is comfort to keep it together in bed. Any number of those things can be quite helpful.
Also, it's very helpful for the parents to be committed to this program. It's very easy for parents to give in to their children, especially at night. It's also soothing for parents to have their children require their presence in the middle of the night, and it's hard to give that up. So really the commitment of the parent to this process is very important.
What that means is that if the child then approaches, like say it's 3 in the morning, a child gets out of bed and gets in the mom and dad's bed, which is all too common, it takes the gumption to get up out of the nice warm bed and take the child by the hand and guide them back to their bed, comfort them, get them back into their bed, get them comforted, and then go back. And again, at 2 or 3 in the morning, that's not easy to do, but it's necessary.
What about medication options? When should that be considered?
Right. Well, the medication option is the last option. The first option is to employ some of these behavioral techniques, have good sleep hygiene, and once you've tried these and they've failed, then we consider the use of medications. Now, there are some medications that we treat children, there's some conditions that we treat children for with medications, which might in and of themselves create insomnia in a child. For example, we treat children with ADHD with stimulants, whose side effect may be trouble falling asleep at night. So if those are the situations that are present, then we try to reduce the dose of that stimulant medication or try to eliminate it and switch to something else. The medications that we generally use to treat insomnia children are not all that effective, and they have side effects. Some of them have been tried are things like clonidine, which is really an antihypertensive medication which is used in adults, but it's used off-label in children to help them sleep because its side effect is sedation, but the side effects can be quite serious in terms of lowered blood pressure and cardiac effects. Some doctors have tried use of the benzodiazepines, which are the minor tranquilizers. They also have the potential side effect of addiction. We've tried some of the antihistamines like Benadryl, which you can get over the counter, and that's somewhat helpful, but you can have a rebound insomnia from that. There are other types of medications which are used to treat children, including the use of melatonin, which is an interesting compound. It's really a hormone that's excreted by the pineal gland, and which is excreted in a circadian rhythm, meaning when the person needs to sleep, they have more of melatonin in their body in preparation for sleep that helps them to then fall asleep. And we have used some low doses of melatonin in children, half hour to an hour prior to sleep, with some effectiveness. Again, there are side effects to that as well. There have been some reports of seizures with this treatment, and it should not be used for children who also have asthma. Except for that, it's pretty safe and is beginning to be quite widely used.
When is it time for a parent to seek professional help? I mean, is it common for a child to have a problem for a while and then get over it, or are most of the children you see having problems for an extended period?
Well, it's a good question in terms of phases, and parents talk a lot about, is my child going through a phase? However, a few measures a few barometers that we use. For example, we talk a lot about severity and duration. How severe is the problem? Is the child's bedtime 8:30, 9 o'clock, and they're staying up until, or they're having trouble falling asleep until 11 or 12? And duration, is this happening, day in and day out for weeks at a time? So those are some measures or some barometers that can be used, as well as just the general impact on the child and the family. Is the child distressed? Is the child complaining, expressing concern? Are the parents concerned about this? It's always best to be safe than sorry, and feel free to give us a call. We can talk about the extent to which it's impacting the family, is causing an ongoing problem. Because again, we talked at the very beginning, at the outset of this, is that these sleep issues can create behavioral problems and even psychiatric diagnoses to come about. And so we want to get a handle on them quickly before they go on for a long period of time. The longer they go on, the harder they are to get a handle on.
All right. We're going to take a short break. We will be back with some of your questions and some research in the news about health topics right after this. You're watching Community Psychiatric Centers Presents on PCNC. Back to Community Psychiatric Centers Presents. In this segment, we take a look at some current health and research topics in the news, and Dr. Lowenstein, here's one for you. Children who sleep less weigh more. What's the basis of that?
Well, they have shown that children who get less than 9 hours of sleep a night are more likely to be quite overweight or obese. Sleep-deprived children have more than a 3% increase in body fat on average compared to youngsters who sleep more than 9 hours of sleep, which is interesting. It's unclear as to why this is the case, but it's important to know that also children that don't sleep as much also are emotionally volatile. They can be more moody and more excitable, and perhaps this can relate to their just overeating in general.
All right, Dr. Crossa, here's another topic. It's a food-related topic. Eating family meals together lowers the risk of eating disorders.
Sound familiar, by the way, in terms of the families eating meals together? We talk about that so often on this show.
Right.
that how families who eat together, it lowers rates of just about everything with teenagers in terms of kids as well, in terms of behavior problems, delinquency, drug abuse, teen pregnancy. Everything goes down. It seems as though the more meals that families eat together. We talked before about how there's a tendency toward that family togetherness, as well as families that eat together tend to do other things together as well. And so that close-knit family unit is very important. However, this research we're speaking of now has to do with the idea that families who eat together, especially their female daughters, their daughters, tend to have less issues with eating disorders. They have a tendency down the line to have less of a tendency, actually, to use extreme measures to reduce their weight, such as extreme exercising, vomiting, not eating for days at a time, diet pills, all those things that people who have eating disorders will tend to rely upon.
What's happening, because you did say it is a familiar topic, what's happening at that dinner table? Is it a bonding, or what's happening that's making all of these negative things go down if you're all sitting around the table?
The act of breaking bread together is a time-honored tradition, and it has emotional and psychological great benefit for the family. They eat together. It's a sign of affection, and it's a time to share thoughts and feelings, and time to bond. Families that are too busy to do that tend to suffer.
Because also, where is the child? If they're not sitting with the family eating the meal, where are they at? Okay, good, they're in front of the television, or they're in their bedroom, and it's a whole different dynamic.
All right, Dr. Lowenstein, low self-esteem is linked to weight gain in girls.
Yes, they have some studies that show that girls that place themselves lower on the social ladder amongst their peers tend to eat more, tend to be more obese, and tend to gain weight over years. This possibly is due to feelings of depression, by which they tend to compensate by overeating, and probably having less sleep.
And the key aspect of that was, though, that it was predictive. When they rated the child's self-esteem levels, they weren't overweight at the time, but those that had lower self-esteem were more likely years down the road to be overweight, which is really remarkable. And of course, one thing I want to take note of about this is that self-esteem is treatable. Self-esteem is something that can be improved upon. And just as an aside, self-esteem is largely accomplishment related. We want children involved in tasks that they're going to achieve in and have fun in and enjoy themselves, and we don't want them in front of the television. We want them out involved in sports and gymnastics and doing fun things, achieving, accomplishing. That's how self-esteem is raised, and that's how we can avoid obesity to some extent.
Let me ask you this, with all of the daily studies that come out and all the research, how do you adapt this into your practice? I mean, when do you know, let me listen to this study versus listen to that study? I mean, how do you know?
One of these studies that we're talking about tonight are really things that we've known all along.
Sure.
They just confirm what we've already known from a clinical perspective, and the studies basically confirm that people, children, girls, in this study, who have low self-esteem, who feel inferior to their peers, tend to eventually compensate for that by overeating and not sleeping very well. And that tends to compound their feelings of inferiority and self-isolation from the group.
And so what we've done all along with children such as this is that we would use cognitive strategies, help them to think differently about themselves, as well as behavioral strategies and getting them involved in those activities that help them to feel successful and improve their self-esteem. We're doing it all along, but now the research is coming along.
And there are good studies to show that girls who tend to exercise more, tend to build their self-esteem back.
Yeah.
So one of the things we'll encourage girls and boys with low self-esteem is to start exercising. Take a handle on your feelings and make yourself feel better by doing that.
So just because they don't have it at present doesn't mean they can't.
Oh, no, goodness.
Absolutely. That's what it's all about.
Oh, yeah.
All right. We're going to take a short break. We will be back with more questions for our doctor, some of your questions from emails you send to cpcwecare.com. We'll be right back right after this. back to Community Psychiatric Centers Presents. A few final questions for our doctors from you, the viewer, and these are email questions. My child wakes up soon after going to bed and is wide-eyed and frantic with screaming. It's really scary. She goes back to sleep in a few minutes and has no memory the next morning. Is this a night terror, and what should I do?
It sounds like a night terror, and clearly, a night terror is described as a child who, in the middle of the night, begins to scream and cry, seems to have a nightmare, intense crying, fearfulness is present. They seem to be awake, but are not really fully awake, and in the morning they don't remember what happened. During the time that you're trying to soothe them and they seem to be awake, they're not fully awake and are responding to some internal event.
What causes them?
Any number of things. It could be sleep deprivation. If a child hasn't been sleeping for a period of time, and that can trigger it, fever, stressful life events. But it's an extraordinary experience. I mean, within a few hours after the child going to sleep, the parents are awakened to just blood-curdling screams, and the child wide-eyed, running around the room. Quite an experience. So it's just important to keep the child safe, guide them back to their bed. Sometimes we can awaken them a few minutes. If we get a sense of when these typically occur, we can awaken them a few minutes before they occur and try to offset it. But they tend to subside as the child approaches adolescence. But God forbid it we're going that long.
It's most probably some form of sleep disorder that affects the sleep cycle. It may involve a neurological cause. EEG changes during sleep are very common, and this may be one of the reasons.
They do tend to be episodic, though. They tend to be experienced for periods of time, and then they subside. But again, quite alarming for parents.
So the symptoms are that they get up, they're screaming.
They get up, screaming, sweating, fearful, panicked, sometimes quite agitated.
Goes on 10-15 minutes, and they'll go back to sleep.
How many of these a week might be happening in some cases?
Could occur nightly.
It could occur nightly.
Wow. It's rare, though.
Okay. Here's another email question. My child has problems with recurrent nightmares. What causes this, and what can I do?
Well, clearly that's troubling for the child. I mean, that's alarming to hear. We want to get a sense of typically there are themes to the nightmares. We can get a sense of, there's one frame of mind that nightmares and even dreams are residue from the day. And so we can get a sense of what stressful events, what trauma possibly the child's experienced. Because when you're talking about recurrent nightmares that are severe, usually it is related to some sort of a trauma or difficulty that happened in the child's life. So we need to get a handle on that.
The child may be experiencing particular stress at a particular point in life. Might involve the death of a relative, might involve their being abused at school, or they're being tormented by a peer. It might involve internal stress within the family, divorce. All kinds of life events can trigger stress and anxiety, which can trigger nightmares. Generally speaking, sometimes the nightmares can be an expression of anger as well as fearfulness. So it's very important to explore with the child not so much what the nightmare might mean, but what's going on in their life that could cause it.
So when is it a good time for a parent to bring a child in for an evaluation? I mean, what would be the trigger, versus this might be some type of phase they're going through? How do you know when it's time to come in?
If the nightmares tend to interfere with the child's life, if the child has other problems besides nightmares which interfere with their life, if their grades are declining, if their social interactions have changed, if they appear withdrawn, depressed, anxious, those are symptoms.
Child's distressed. They don't want to go to sleep. They're fighting sleep because they're afraid of having a dream. They're distressed throughout the day, thinking about what may happen tonight. I mean, those are all signs. Again, severity and duration. It is a severe situation that's going on for a while, and parents need to seek help.
Do parents always know what questions to ask to elicit a real, genuine response from the child as to what might be causing it? Or sometimes is it the skill of a professional that can bring out some things that a parent might not even know to ask?
Well, it depends on the parent. There's some parents that are very insightful, that are in tune with their child's lives and in tune with their feelings, and they might know themselves what's causing this. And then there are other instances where parents really do do not know what could have caused it, what kind of life events might have triggered it. In those instances, it's important to bring the child to a professional to try to uncover and resolve these conflicts.
It's a great question because, again, that's the training of a clinician, to know what to ask and how to ask it, to know the timing to ask it. And that's what goes into the training and experience of being a clinician. Parents can do a wonderful job, but professionals, are necessary at times.
All right. Thank you both for being with us, and thank you for watching. We'll see you next week on Community Psychiatric Centers Presents. Good night.